Good day, Sudipka. I'll be back. Good day, Mila. Are you there?
Good afternoon, Dr. John. Good afternoon, everyone.
How are you doing?
I'm good. How are you?
Good. No one's here yet, but don't worry, there'll be people.
Sure, no problem.
People tend to come later and later.
All right.
But since they have 5 presentations, there's gotta be people coming.
Yes.
I'm just getting my background set. Yeah, I would basically like to have you be Neurosurgical TV. Basically to represent, because I want to get out of it. I want you guys, the neurosurgery people, students. I've tried it different times. People come and go. But
Yes.
yeah, you can try it. And I'm going to go 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. After I say 1, hi, I'm Mila from so-and-so of Neurosurgical TV. We have the honor or pleasure of having, there you go.
All right.
Hi, Sudipka, are you there?
I am available.
Okay. I'd like you to meet our newcomer here that's going to introduce, be the host. This is Mela Mangi. She's from
Hello,
Turkey.
Professor.
Welcome, doctor.
Thank you.
She's in Russia, from Turkey.
From Saudi.
Oh, you are from Saudi. I am from Bangladesh.
That's lovely to meet you.
Our teacher, our honorable joint director of the institute, he is available now, Professor Badrul Alam sir.
Yes, you can hear me?
Yes,
Yeah.
sir. We
Yeah,
have.
yeah. I am with you.
Yes, sir.
You have your camera working, Dr. Alam?
Okay, Dr. Arman will join very soon.
Oh, okay, she's not joined yet. Oh, she's in now. She should be able to.
Today we have 5 speakers, Dr. Maidul Islam, Dr. Tarek, Dr. Arman, Dr. Sweet, and me. So we have 5 speakers today.
Okay, now Mila, should she introduce you and you're going to introduce every speaker? How do you want to do it?
So after your general introduction, I can introduce our teacher first, Professor Badrul Alam sir, and he will initiate the program or he will start the program. After then, one by one speaker will deliver their speech. So we can start very soon.
Yeah, we'll just let you take off and you do what you have to do.
DM Arman already in online. He sent good afternoon. Arman bhai.
We have a few minutes here.
John, can you give acceptance of entry of Dr. Arman?
Dr. Alam is here.
Yeah, he is Dr. Maidul Hassan. He is the first speaker.
Okay, who else do we need in? That we don't have anybody else waiting to come in yet. We can wait a minute. Who are you waiting for?
Dr. DM Arman, he is waiting.
Don't have anybody in the waiting room. He's not in the waiting room. Does he have the right link?
আরমান ভাই আপনাকে ওয়েটিং রুমেও পাওয়া যাচ্ছে না।
Yeah, let me give you a link here. To Dipka. I'm gonna put it in the chat, okay? That's a direct link to come in the panel. You see the link? I'll put it in the chat. Oh, Dr. Armand's here.
Dr. Maidul, where is Dr. Tarek? Dr. Maidul?
He should be in. Dr.
Dr.
Armand,
Dr. Maidul, please inform Dr. Tarek and we can start.
Okay, sir.
okay, are you ready?
Dr. Arman is available now.
Oh, good, good. Good day. Welcome.
Most welcome.
Okay, everyone, this is Mila Mangi. She's the neurosurgeon from Turkey and Russia. She's going to be hosting. Okay, you ready, Mila?
Yes.
Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
Good morning, good afternoon, and good evening, everyone. Welcome to Neurosurgical TV. Today we have the honor of presenting our speakers from Bangladesh. My name is Mila Mangi. I am from Saudi Arabia, but I'm currently a neurosurgical resident in Russia.
Good afternoon, Milo. This is our 5th episode of Pediatric Neurosurgery Grand Round from Bangladesh. So this is a series of webcasts jointly collaboratively delivered by Neurosurgical TV as well as our hospital, that is National Institute of Neurosciences and Hospital, Dhaka, Bangladesh. Today, we are very much happy and proud. Our teacher, our joint director, he is one of the founder of our hospital also. He is a guardian of our pediatric neurosurgery. Truly speaking, I came in the subject pediatric neurosurgery in his influence. So Professor Badrul Alam sir, he will started this program. After then, we have 5 speakers. Dr. Maidul Hassan Shoikot, he will the first speaker. Professor Badrul Alam sir, please.
Thank you, everybody, participants from home and abroad. This is very appreciable, and I think I feel honored that you have appreciated me as a joint director of this institute. You know, the Bangladesh is the country where tremendous people, tremendous children suffering from various neurosurgical disorder, particularly brain tumor, hydrocephalus, meningocele, meningomyelocele, and so and so. So in this respect, the international collaboration between the neuroscience and the other faculties of the world, they are giving very support to our people, particularly for the training and the working environment in our country, and so that we are taking knowledge from outside. And for that reason, this type of webinar is very much important for our country, for our people, for our students, and also the trainee doctors and the faculties. So today's webinar will help us to do something for the near future, and our representatives, particularly the Dr. Arman and other people who are present today, I think the discussion will give us some idea to uphold the seminar again. Thank you very much. Please go ahead. Dr. Sudipta, yeah.
Please unmute.
Thank you, sir, and for giving us a positive, inspiring talk for our department, for our future. And today, Dr. Maidul Hassan Shoikot, he is the final year resident. He is the first speaker of today's fifth episode, and this is the second episode of brain tumor session. And Maidul Hassan Shoikot will present terional craniotomy. Dr. Maidul, please.
Thank you. Hello, everyone, for giving me the opportunity to present today's topic.
Okay, Maidul, share your screen, please.
Yes, sir. Can you see my presentation?
Fine.
Okay. So I'm going to present about terional craniotomy today. I am Dr. Maidul Hassan Shoikot, a resident of neurosurgery from NITS, Dhaka, Bangladesh. Terional craniotomy is a versatile and familiar transcranial approach for neurosurgeons. It is also known as frontosphenotemporal craniotomy. This craniotomy was popularized by Yasser Gill as an approach to intracranial aneurysms and is now the most widely used approach in neurosurgery. So the question is, where is terion? It is the region of skull where four bones are approximated, and they are frontal bone, parietal, temporal, and greater wing of sphenoid bone. The estimated location is about 2 finger breadths above the zygomatic arch and a thumb's breadth behind the frontal process of zygomatic bone. These pictures depict the surface anatomy of terion, which is shown as 2 fingers breadth above from the zygomatic arch and 1 thumb breadth posterior to the zygomatic bone. Now you can see that the blue circled marked area is the terion, which is formed by joining of multiple suture lines such as coronal suture, sphenozygomatic suture, sphenosquamosal suture, sphenoparietal suture, and squamosal suture between temporal and parietal bones. Now, what are the goals of this craniotomic approach? The exposure of lesions affecting sylvian fissure, anterolateral frontal lobe, anterior temporal lobe, anterior and middle cranial fossa, circle of Willis, cavernous sinus area, sellar suprasellar region, orbit, superior orbital fissure, and other adjacent areas. The triangular area marked as red outline is our area of interest through terional craniotomy. The indications of this craniotomy are tuberculum meningioma, sphenoid wing meningioma, cavernous sinus meningioma, craniopharyngioma, pituitary adenoma when there is a large suprasellar component, some types of gliomas, all aneurysms of anterior circulation such as ophthalmic artery, posterior communicating artery, internal carotid artery, middle cerebral artery, anterior communicating artery, etc. Less commonly, basilar tip aneurysm. Now first comes the positioning of the patient in operation theater. Supine position and rigid head fixation with Mayfield 3-pin skull clamp. The double pin placed inferiorly on the ipsilateral retroauricular region. The single pin situated behind or at the contralateral hairline within the sagittal plane of mid-pupillary line. Head rotation towards contralateral side for 15 to 30 degree for most of the lesions, but may vary up to 60 degree depending on size and location of lesions. You can see various degree of rotation of head according to the site of lesion. The head is rotated about 30 degree when we want to expose the posterior area, such as lesions of like posterior communicating artery aneurysm, basilar tip aneurysm, clinoidal meningioma, etc. The head is rotated about 45 degree in case of middle exposure, such as ICA, MC aneurysm, terional meningioma. The head is rotated about 60 degree to the contralateral side in case of anterior exposure, such as anterior communicating artery aneurysm, or any suprasellar space occupying lesion. The ipsilateral shoulder roll of head turned about more than 30 degrees to lessen neck torsion and internal jugular venous occlusion. Neck extended 15 degrees to make the zygoma the highest point, allowing gravity to retract frontal lobe away from the skull base. Thorax is elevated 10 to 15 degrees to ensure the head is above the heart to optimize venous return and therefore reduce venous distension. Both knees are flexed. The next step is skin flap. A curvilinear skin incision starting from zygomatic arch at the level of tragus, curving anteriorly, staying behind hairline to widow's peak. Optional additional curve beyond midline to aid in skin retraction, which is known as bicoronal incision. Incision is made 1 centimeter anterior to tragus commonly or at tragus to preserve parietal or frontal branch of superficial temporal artery respectively, as well as frontal branch of facial nerve. Here you can see in the first picture, the incision line, which is located behind the hairline, and the course of frontal branch of facial nerve, about 1 centimeter anterior to tragus. The second picture shows that there is a pad under the ipsilateral shoulder to avoid neck torsion. In belt patients, it is extended where the forehead curves horizontally, thereby making the incision less visible when facing the patient. The superior part of temporalis muscle is exposed along the superior temporal line and muscle incised along this line to fashion a myofascial cuff. This will aid reattachment of the temporalis muscle at closure. The scalp and muscle are retracted by fish hooks. In this picture, you can see the myofascial cuff and the temporalis muscle flap is everted, exposing the keyhole barhole point. And the dotted black line shows the craniotomy, which is planned. Now come the bone flap. Usually 2 barholes are used to make terional craniotomy. One in the squamous portion of the temporal bone just superior to the root of the zygoma, and the second one at the McCarthy keyhole. It is made just behind the orbital rim at the anterior aspect of superior temporal line. The hole is so named because it is the key to entering the anterior cranial fossa, middle cranial fossa, and orbital compartments. Here you can see the craniotomy outline and 2 barhole points. This picture shows you the handling of craniotomy. First 2 pictures shows the correct technique of handling this device, which is known as pen holding manner. But the third picture shows you the wrong manner of holding a craniotomy. This picture shows you the angulation of the craniotomy. The craniotomy should be moved maintaining a 90-degree position, which is shown in the first picture of this slide. Tilting the craniotomy anteriorly pushes the footplate into the dura, so there is chance of injury to dura mater. Occasionally, their third barhole is placed posterior to the keyhole barhole along the superior temporal line. The dura is separated from overlying bone by pen-filled dissector. The craniotomy is used to cut the bone flap, starting at the keyhole and advancing the cut medially, close to the orbital ridge to lessen frontal lobe retraction. The cut is then swept posteriorly and inferiorly, joining the other barholes. The cut from the root of the zygoma begins inferiorly and advances anteriorly until the craniotomy hangs up at sphenoid ridge. This part of sphenoid bone is thinned by drill bit and fractured to avoid injury to the underlying dura mater. Free bone flap is separated from the underlying dura. A ronger is used to remove as much sphenoid wing as possible. Here you can see the outline of terminal craniotomy as red mark, but the dotted black. But the dotted black line.
Shaykh Jahid sir said he is not hearing.
Can you hear me now properly?
Yes,
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 we
fine,
can.
you're fine.
Okay.
okay, you can start.
This picture shows you the outline of terminal craniotomy, but the dotted black marked area shows the bone to be fractured here to avoid injury to the underlying dura mater. This is the perioperative images after removing the bone flap. The second picture, you can see that the adjacent dura mater is separated carefully from the overlying bony outline. Here, flattening of the sphenoid ridge by a diamond drill in the first picture or a ronger in the second picture for the purpose of smoothing the bony ridges. After removing the bone flap, multiple points are drilled for the purpose of dural tinting. The second picture shows you that there are stitches for multiple dural tinting. The purpose is to avoid post-operative development of extradural hematoma. Now moving on to dural flap, curvilinear centered over sphenoid wing, retracted inferiorly with dural stitch. The first picture shows you the making of dural opening with a dura cutting seizure. And the second picture, you can see that the dural flap is everted inferiorly, exposing the underlying brain parenchyma and adjacent important blood vessels. Now arachnoid dissection. The sylvian fissure is split using 1 cc insulin syringe under microscope. This can be done from lateral to medial aspect or by starting at the point where carotid artery penetrates the fissure and then laterally. The extent of dissection will be dependent on location and size of the lesion. Exposure of structures through terrenal craniotomy are parenchymal structures such as sylvian fissure, inferior frontal gyrus, superior temporal gyrus, middle temporal gyrus. Arachnoid layer including optic and carotid cisterns among cranial nerves, second and third cranial nerves, and optic chiasma. Among the arteries, ICA, M1 segment of MCA, A1 segment of ACA, basilar artery, and among the veins, superficial sylvian veins and vein F labae can be exposed through this approach. This picture shows you the perioperative image after arachnoid dissection and sylvian fissure dissection. Here are some important neurovascular structures are shown, such as third cranial nerve on the right upper aspect, and on the left side there is optic nerve. OCT depicts oculomotor carotid triangle located between third nerve and ipsilateral ICA, and the bifurcations of ICA such as MCA and ACA are also seen, and some portions of inferior frontal gyrus are also seen on the lower aspect. Now coming to closure. After performing the definitive surgical procedure, there comes the closure. Dura closed with continuous 4-nil vicryl suture in watertight fashion. Bone flap is repositioned either by polypropylene suture including central tenting to avoid extradural hematoma or titanium plates and screws. Then temporalis muscle and fascia reapproximated to the myofascial cuff. Finally, gallia closed with interrupted buried suture and skin with staples. Here you can see the steps of the closing procedure. The first picture shows you the watertight dural closure, followed by repositioning of the craniotomy bone flap, either by polypropylene suture on the right picture or by multiple titanium screws and plates shown on the left picture. After repositioning the bone flap, the temporalis muscle is reapproximated to the myofascial cuff by vicryl suture. And finally, the left picture shows you the gallial closure by continuous buried suture and then skin staples. So here ends my presentation. Thank you everyone for patience hearing.
Thank you, Dr. Maidul, for your excellent presentation. As a resident, your presentation is rich in patient position, angulation. Here in pediatric neurosurgery, we every day expose this type of vessel through renal craniotomy for craniopharyngioma and chiasmatic hypothalamic glioma surgery. So thanks for your excellent presentation. And I invite next speaker, Dr. Shifat Jamil Tarek, for posterior midline suboccipital craniotomy. Dr. Shifat Jamil Tarek, please deliver your presentation.
Can you hear me, sir?
Yes,
Yes, we can.
please share your screen.
Sir, can you see my first slide?
Not
Not yet.
yet, not yet.
Not yet.
Yes,
Have you started it?
Sir, can you see?
Not yet. Okay.
now
Yes,
please,
we
please
can
make
see it.
full screen.
Perfect.
Yes.
Thank you, sir. Respected faculties, my respected teachers and audience. I'm Dr. Shifat Jamil Tarek, resident, PhD resident of National Institute of Neuroscience Hospital. Today I will discuss about midline suboccipital craniotomy, one of the commonest surgical intervention done in pediatrics and other faculties, other branches of neurosurgery. These are the some points about midline suboccipital approach or craniotomy. This approach allows the exposure to one or both cerebellar hemisphere, cerebellar vermis, fourth ventricle, foramen magnum, and other structures. Suboccipital craniotomy can be done in either sitting or prone position. C1 laminectomy or laminectomy can be done, which allows for a more extensive exposure for the inferiorly extended lesions. Now comes positioning. Both the midline and paramedian approaches can also be performed with the patient in either the prone or sitting position. The prone position has the advantage of minimizing the likelihood of air embolism, achieving the controlled release of CSF. But in sitting position, the advantage are blood by virtue of gravity drains out of the field, operative field. Ventilation is unencumbered. Venous drainage may be enhanced, thus reducing intracranial pressure. But the disadvantage in sitting position is air embolism and surgeon's arm fatigue. Concord position. For midline lesions, the Concord position is usually used, which is a modification of prone position. In Concord position, patient will be in prone, thorax elevated 20 degree, neck flexed and tilted slightly from the side of which the surgeon will be standing. This is the position, some of the aspect of Concord position. If the prone position is chosen, the head is placed in Mayfield three-point fixation. The patient is placed on chest rolls and all pressure points are well padded. In the sitting position, 3-point fixation is also used. However, precordial Dopplers and central venous line to the right atrium should be placed to detect and evacuate air embolism. These are the precautions taken in sitting positions, complication that may arise in sitting position. Now comes skin incision. The skin incision uses knowledge of several surface landmarks or surface landmarks, which includes mastoid process, inion or external occipital protuberance, spinous process of C2, C1, C2, and lower cervical spine if the incision is extended. The transverse sinus runs approximately from the level of the inion to the external auditory meatus. Here you can see this in this picture. The sigmoid transverse junction is near the mastoid notch. The sigmoid transverse junction is near the mastoid notch. The sigmoid sinus is under the mastoid groove. For a midline suboccipital approach, the skin incision begins 2 to 3 cm above the inion and is carried to the upper cervical spine region. Now comes the underlying dissection, subcutaneous dissection. The underlying muscles are retracted or stripped away from the suboccipital bone. Upper cervical lamina or posterior arch of the C1 and spinous processes in a subperiosteal fashion, dissection done in subperiosteal fashion. Cerebellar or band Edson or mastoid self-retaining retractors are used to maintain adequate exposure. For paramedian incision, the occipital artery must be identified and coagulated appropriately to maintain intraoperative and postoperative hemostasis. Either a craniotomy or a craniectomy can be performed. Here is a typical picture of craniotomy, outline of craniotomy outlined in this picture. But if we go for craniectomy, craniectomy implies removal of bone, often in a piecemeal fashion, with no intention of replacing the bone fragments. The advantage to not replacing the bone is that if there is post-op swelling, the inelastic bone flap may cause more pressure to be transmitted to the brainstem. A downside or a disadvantage to not replacing the bone is that local pain and or syndrome of the trephineum may be more common. The bone opening is usually taken down to foramen magnum. Now comes durotomy. For the midline approach, dura is generally opened in a Y-shaped fashion. The straight limb of the Y is carried down to the region of the foramen magnum or below if the pathology extends into spinal canal. The inferior sagittal sinus occasionally is prominent and require ligation. Dural flaps are reflected superolaterally and held by stitches. Cerebellar hemispheres and vermis come immediately into the arachnoid over the cistern magna is then entered. Here is in this picture you can see that after durotomy, these are the two cerebellar hemisphere suboccipital surface, and this is the artery, posterior inferior cerebellar artery, and this is cerebellar tonsil. As the arachnoid is separated, the cerebellar tonsils are seen. Previous picture have shown the tonsil, cerebellar tonsil. Cerebellar tonsils are seen abating in the midline. Inferiorly, the lobes of the pica may be seen in relation to the tonsils. These are the pica, medial trunk. This is cerebellum, and this is vermis. So pica may be seen in relation to the tonsil. Pica anatomy may be variable. Therefore, a review of the preoperative angiogram can be done. The tonsil may be carefully mobilized by sectioning arachnoid bands. Then they are retracted laterally with self-retaining retractors, taking care not to injure or compress the important vessel pica. Now we going to deep in the fourth ventricle. As the tonsils are retracted, the foramen magentae is opened and floor of the fourth ventricle can be seen. This is the floor of the fourth ventricle. This is obex. This is pica, lateral trunk. This is uvula, and this is medial trunk of pica and inferior medullary velum. Here you can see the upper portion of the picture. To reach the lateral recesses of the fourth ventricle, the tonsils and the flocculus of the cerebellum need to be mobilized further by incising, tethering arachnoid bands and retracting laterally. As the tonsils are retracted laterally, the inferior medullary velum can be seen covering the region of the foramen of Luschka. The inferior and lateral portions of the ventricles are now visualized to view the upper part of the fourth ventricle, and a small incision is made in the inferior section of the vermis between the vermian arteries, and two cerebellar hemispheres are retracted laterally. The upper portion of the ventricle and aqueduct orifice can be appreciated. In this picture, this is median sulcus, this is facial colliculus, this is median eminence, tria medullaris, vagal triangle, area posterior or vomiting center, inferior cerebral peduncle, and this is hypoglossal triangle. Now comes closure. Closure of the posterior fossa must be in a watertight fashion. Occasionally will require the use of dural substitute or autologous grafts. The muscles and skin should be closed in multiple layers to act as barrier against CSF leak, which is very common in posterior fossa approach, posterior fossa lesion. Important consideration: good hemostasis must be achieved. Postoperative hematoma, avoid sinus injuries, avoid cerebellar contusions, avoid vascular compression or injury, especially to pica, watertight closure to prevent CSF fistula, and yard embolism, which can be a major problem in sitting position. This is the end of my presentation. Thank you all for your patience hearing.
Thanks, Dr. Shipat Jamil Tarek, for your excellent presentation. That is a unique presentation for approaching the posterior fossa midline, especially the cerebellar fourth ventricular pathology, as well as pathology of upper cervical spine. Your presentation and content was excellent. Anyhow, you can recheck and modify one slide where you mention about the knotting of inferior sagittal sinus. Please state it is occipital sinus. So I invite Dr. D.M. Arman for his presentation, that is transcranial approach for craniopharyngioma. This is a continuous presentation. In the last presentation, he presented about endonasal approach of craniopharyngioma. We know craniopharyngioma is not always possible to perform surgery by endonasal approach. So he will present transcranial approach. Dr. D.M. Arman, please.
Can you hear me?
Yes.
Yeah, Professor, we can.
I'm sharing my screen.
All right.
Can you
Okay.
see me?
Perfect.
Yes, we can.
Thanks, Dr. S.K. Mukherjee. This is fifth session of pediatric neurosurgery webinar series organized by Department of Pediatric Neurosurgery, National Institute of Neurosciences, Dhaka, Bangladesh, and John Bennett of Neurosurgical TV. I'm Dr. D.M. Arman, going to present my talk on pediatric craniopharyngioma transcranial approach. This is National Institute of Neurosciences Hospital. This is 500-bed hospital situated at Dhaka, capital of Bangladesh. We have more than 40 neurosurgeons work here and did near 3,000 operations in last year. In our director, Professor Kaji Din Mohammed sir, and here to represent Professor Dr. Badrul Alam sir, Joint Director, also President of Bangladesh Society of Neurology. I must thank both of you, sir, for your dedicated and dynamic leadership and to ensure good working environment and to provide latest technology and equipments in our OT arrangements. Thank you, sir. In Department of Pediatric Neurosurgery, we did 538 operations in 2022. Regarding craniopharyngeal surgery, last few years, we did 70 craniopharyngeal surgery. In most of cases, we did through transcranial approach. Introduction: craniophryngiomas are benign epithelial pouch and tend to arise from anterior superior margin of the pituitary. Craniophryngiomas are 0.8% of the all brain tumors. They comprise up to 10% of pediatric brain tumors. Almost all craniophryngiomas have solid and cystic component. Calcification present in 50% of the cases. There are two histological types. Type 1, adamantinomatous. It has bimodal age distribution. Childhood peak age 5 to 15 years. Adult peak age 45 to 50 years. Type 2, papillary, occurs in adults with mean age 40 to 55 years. CT scan and MRI of brain is the diagnostic tool of craniophryngiomas to see the location and extent of the tumor, relationship of the tumor of surrounding structures, involvement of visual pathway, hypothalamus, third ventricle, and also see the content of the tumor, cystic, solid, or calcium part of the tumor. There are variable sizes less than 2 centimeter considered as small, 2 to 4 centimeter medium, 4 to 6 centimeter large, more than 6 centimeter considered as a giant craniophryngiomas. Giant craniophryngiomas may extend into multiple or all compartments extending from foramen of Monro to medulla. Craniophryngiomas are classified into intercellular, intersupracellular, supracellular, and intra-third ventricular types based on location. Tumor location is the key for choosing an optimal surgical approaches for craniophryngiomas resection. Craniophryngiomas are historically benign tumors, yet they may carry an unfavorable prognosis. Historically, aggressive surgical resection was the treatment goal to minimize risk of tumor recurrences by open transcranial approaches, but could have to clinical sequelae of visual, endocrine, and hypothalamic dysfunction. There are many approaches for successful craniophryngiomas resection. The goal of surgery remains the maximally safe resection, emphasizing the preservation of visual, endocrine, hypothalamic function, maintain quality of life in these patients. Although craniophryngiomas is a benign tumor, the tendency of craniophryngiomas to adhere to adjacent neural tissue and vessels make excision technically difficult and increases the chance of morbidity and mortality. Actually, to choose approach of the craniophryngiomas resection, the location and its expansion of craniophryngiomas and involvement of the surrounding structure and surgeon's expertise is important to choose the approaches for craniophryngiomas resection. Two main approaches, transcranial approach and endoscopic endonasal approach. The most common transcranial approaches are we use mainly terional or phonotemporal craniotomy, orbitozygomatic craniotomy, and use subfrontal approach, and also use transcallosal and mini craniotomy, that is supraorbital craniotomy. In cystic craniophryngiomas with hydrocephalus, we usually endoscopically cyst aspiration resection with reservoir placement in few cases. It is not a definitive treatment. It may reduce the symptoms. The introduction and refinement of the endoscopic intranasal approach has revolutionized surgery for craniopharyngioma. Usually, transsphenoidal approach in few cases need extended approach. Transcranial approach remains the preferred approach for craniopharyngioma. It has several approaches: pterional or jargomatic, and in pterional approach, several corridor we use. This is prechiasmatic and subchiasmatic opticocarotid between optic nerve and carotid artery, and translamina terminalis and lateral to the carotid. Advantages of transcranial approach, which allows greater movement of freedom, reach to purely third ventricular tumors, reach to tumors with significant lateral extension, excellent visualization, control of major arteries. Transcranial approach is indicated in large and gigantic craniopharyngioma, cystic and solid suprasellar tumors entirely within the third ventricle. Intracellular tumors are the relatively contraindicated in transcranial approach. In pterional subfrontal approach, we use several corridors: prechiasmatic, subchiasmatic, optic-carotid, carotico-oculomotor, and translaminar terminalis. Translaminar terminalis, when craniopharyngioma extends to the third ventricle or significant rectochiasmatic component, you know, translaminar terminalis is a thin sheet of gray matter, looks pale and avascular, often distended by tumor. Surgical technique in craniopharyngioma: internal decompression and dissection of the capsule arachnoid plane. Greater care should be paid to differentiate the tumor from hypothalamus and pituitary stalk. No hypothalamic involvement, total resection, and hypothalamic, in case of hypothalamic involvement, subtotal resection followed by radiotherapy. Now we show few cases with craniopharyngioma. 13 years old boy presented with headache, vomiting, and visual disturbance. This is CT scan of this patient. Short cellular lesion, hyperdense area shown, and this is cystic portion, this is solid portion, and also still calcium component. And tumor enters into the third ventricle and adheres with hypothalamus. This is MRI of the brain in different section. Lesion in cellular and supracellular region, mostly cystic and also solid part, occupied third ventricle. His visual assessment: 6/9 on the right eye and finger count from 5 feet on the left eye, and visual field reveals grossly depressed vision. This is fundal photograph of this child. This is surgical video. After craniotomy, we dissect Sylvan fissure. For Sylvan fissure dissection, we use insulin syringe, needle, or microseizure. medial part of the sylvian fissure. We cut arachnoid to release PSF. We dissect arachnoid over optic nerve, and this is IPA on the right side. We dissect arachnoid and to release opticocarotid cistern and release PSF. You see continuous dissection in front of the chiasm. This is pre-chiasmatic space. You see behind the chiasm, this is lamina terminalis. This is lamina terminalis. You know, lamina terminalis is a thin sheet of gray matter, looks pale and avascular. We open lamina terminalis by bipolar diathermy. Try to decompress internally. Care should be taken during dissection from hypothalamus and floor of the third ventricle. This is calcium part adherent to the tumor capsule. We try to separate from capsule. We dissect delicately from surrounding structure. Dissection continuing, and we removed capsule of the tumor. Principle is no pull. Meticulous dissection is made from surrounding structure. We remove tumor capsule piecemeal by piecemeal. This portion of the tumor attached to the optic tract, and this is its lateral optic tract, and this is IPA. We use opticocarotid corridor to release capsule of the tumor. This is pre-chiasmatic corridor. We check care should be taken not to injure the floor of the third ventricle or hypothalamus. This is contralateral optic nerve. This is ipsilateral optic nerve. This is chiasm. This is optic tract. After tumor removal, hemostasis is done. And this is post-op CT scan. Seems to be ghost total resection. And in post-operative period, he developed diabetes insipidus. We managed well, and on the day of discharge, he was discharged with thyroxine and cortisol. He's in our follow-up. Next patient, 15-year-old girl, presented with headache, vomiting, blurring of vision. CT scan showed cystic lesion in sellar and suprasellar region. This tumor also goes into the third ventricle. MRI showed cystic cuneiform tumor in sellar and suprasellar region. You see where tumor goes. This is inside the third ventricle and pushes the hypothalamus upwards. This is surgical video. After craniotomy and cerebral fissure dissection, we open lamina terminalis. Initially, internal debulking. We try to dissect opticocarotid corridor. Now, inside the tumor, try to dissect from surrounding structure. Careful dissection is made from surroundings. Capsule of the tumor is removed in piecemeal fashion. We cut tumor capsule piecemeal fashion. We try to dissect meticulously capsule from surrounding structure. We try to maintain dissection in capsule arachnoid plane. This is ACA. Last piece of capsule. Tumor is removed from third ventricle. Hemostasis was achieved through the surgical. This is chiasm, this is contralateral optic nerve, this is ipsilateral, this is optic tract, this is pre-chiasmatic corridor. After operation, this is postoperative CT scan, showed rostral resection. In postoperative period, she also developed diabetes insipidus. We managed well, but he need occasional minirin, and she was discharged with thyroxine and cortisol. This is a picture of girl on the day of discharge. This is another 2 years boy presented with headache, dimness of vision. This is MRI picture of this boy, showed cystic prenipharyngioma in sellar and subcellular region. Here you see tumor pushes the floor of the third ventricle, and he presented with dimness of vision in both eye. This is frontal photograph of this boy, and this is surgical video of this boy. You see, this is pre-chiasmatic space. We try to dissect from contralateral ICA. Here is, you see, this is contralateral ICA. We try to dissect meticulously. This is contralateral optic nerve. We dissect tumor capsule interoptic space, also subchiasmatic area. Tumor capsule is highly adherent to the undersurface of the chiasm, also hypothalamus. Then we decided to some portion of the tumor is left behind with chiasm and hypothalamus. This is postoperative CT scan of brain. Looks okay. This is another girl, 8 years old, presented with headache, vomiting, blurring of vision, and right-sided witness. CT scan showed giant cranipharyngioma comprised of cystic and solid part, and MRI shows this cranipharyngioma involves multi-compartment. Anteriorly, it extends in the inferior surface of the frontal lobe, and it extends into the third ventricle and adheres with hypothalamus, and also touches the midbrain brainstem, and also goes on the right side, inferior surface of the temporal lobe also. And we see huge calcium part of the tumor. This is giant cranipharyngioma. Her visual acuity 6/6, but field examination showed hemianopy on the right side, markedly depressed visual function on the left side. This is her frontal photograph. This is surgical video. As I said already, this is giant cranipharyngioma. It involves multi-compartment. You see, enters into the Sylvian fissure. You see the tumor comes into the surface. And this is cystic portion came out. We suck it. Tumor adherence, surrounding structure. We try to dissect meticulously from vessels, nerves. You see how much adherence in neurovascular structure. This is ipsilateral optic nerve. Now we are in interoptic area. Tumor is everywhere, in all compartments. We try to dissect and remove piecemeal fashion. This is ipsilateral optic, this is contralateral optic. We are in interoptic area. Huge tumor bulk. We try to remove tumor from middle surface of the ipsilateral optic and inferior surface of the optic nerve. And after tumor removal, we did post-op CT scan of brain, and this is post-op CT scan without contrast, almost gross total resection. And this is our patient the day of discharge. He also have diabetes insipidus. Unfortunately, his vision reduced to PL, and she was discharged with mineral, low dose, cortisone and thyroxine. This is our another patient, 9-year-old boy, presented with headache, blurring of vision. This patient, this is cystic nephrangema, developed hydrocephalus. We decided to do endoscopic cyst aspiration and cerebral reservoir placement. This is pre-op picture. This is post-op picture. You see the tip of the cerebral reservoir here. This is not a definitive surgery in nephrangema. This is temporary measure to relieve symptoms immediately, and later on we must do definitive surgery. This is another boy, 13 years, presented with headache, dimness of vision in the left eye. This is cystic nephrangema, pushes floor of the third ventricle upwards. We decided to do endoscopic cyst aspiration and cerebral reservoir placement. Here you see this is flexible endoscope. Cystic portion of the tumor is aspirated through this port, and this is endoscopic picture. tip of the cerebral reservoir goes inside the cyst, and this is inside picture, endoscopic picture. This is tip of the cerebral reservoir, and this is post-op picture. And you see at Cocker point, dome of the cerebral reservoir placed here. When emergency arises, we can easily aspirate fluid portion of the cranioparenchyma from this dome of the cerebral reservoir. One year, 6 months old girl presented with headache, vomiting, and dimness of vision in the both eye. This is pre-op picture, peripheral calcification seen here, and this is MRI picture. And after operation, we see total excision of the tumor, and patient is stable. We follow her. We did this operation 7 years ago, transcranial approach, and earlier in this year, we did MRI and see no recurrence. And recently we did another CT scan, we see no recurrence. But in cranioparenchyma surgery, total excision is not all. There are many complications after operation. You see this girl, after total excision, he remained blindness in her both eyes. He dependent on cortisone, thyroxine. She gained obesity, and she has growth retardation. So many complications after cranioparenchyma surgery. So only surgery is not the answer. So many endocrine disturbances happen after operation as a result of pituitary stroke and hypothalamic manipulation. Total or near total resection have more risk of complications such as hypopituitarism, hypocortisolism, hypothyroidism, growth hormone deficiency, hypogonadism. Diabetes insipidus universally present immediately following surgery. It's common. We must care after operation regarding fluid balance. Where need, we give vasopressin. Another complication is obesity due to hypothalamic injury, followed by increased appetite, hyperphagia, and that results in morbid obesity. Many of the patients dependent on cortisone, thyroxine, and other hormone therapy. And after operation, deterioration of the visual function is the other complication of this surgery. Recurrence is common in cranioparenchyma surgery. Most recurrences in children develop within 2 to 3 years. In gross total resection, no need of radiation. Accessible tumor left unresected. Second operation within the several weeks of primary surgery is the surgical option. In subtotal surgery, needs radiation. Radiotherapy is indicated in recurrent cranioparenchyma or in subtotal resection. Endocrine dysfunction and optic neuritis and cognitive impairment is the side effects of radiotherapy. So, due to cognitive impairment, radiotherapy is contraindicated below the age of 3 years. In conclusions, cranioparenchymas are histopathologically benign but clinically aggressive suprasellar tumor. The management paradigm for cranioparenchymas has shifted from aggressive resection to maximally safe resection, emphasizing quality of life issues, particularly in regards to visual, endocrine, and hypothalamic function. The management of cranioparenchymas requires multidisciplinary approach involving neurosurgery, endocrinology, otolaryngology, ophthalmology, and oncology. This is end of my talk. I am stopping here. Thank you very much, everyone.
Thank you so much, Professor. That was an amazing presentation.
Thank you, Dr. D. Barman, for your elaborative and associated video presentation regarding craniopharyngioma. Craniopharyngioma actually nowadays is still now not only under control of surgery, but the philosophy of removal of craniopharyngioma is different in different centers. In some center, they always believe radical removal of craniopharyngioma is the goal of treatment. Like in Japan, they always believe radical removal as because they have good community support. Like they have community support regarding endocrine management and others. But most of the country, they rely on safe removal, not on radical removal. We, in our center, our target is safe removal, though its recurrence rate and complication rate is very high. So our next presentation is my presentation. I am Dr. Sudipta Kumar Mukherjee. I present my topics is medulloblastoma. Medulloblastoma, this is my second presentation. In first presentation, I was talking about the medulloblastoma diagnosis, its histopathology and its future and modern management. Today, I am talking about actually the surgical tips and tricks of medulloblastoma. Though there is a lot of tips and tricks, John or Mila, can you see my screen?
Yes, Professor.
yeah,
We can
yeah.
see it.
So I can proceed.
Yeah.
So surgical anatomy study is the important issue for knowing the tips and tricks of any surgery, especially in pediatrics. Pediatrics is not a copy of adult. There are some developing anatomy and physiology in case of pediatrics. So we must know what is the difference in between both anatomy and physiology in case of pediatrics. The next thing is the surgical techniques. So our aim is maximum safe removal of tumor. So this is the target zone where we want to enter. This is the target zone, that is the midline, both cerebellar hemisphere, and this is the foramen of Mezendy. So this is the important structure. You know the telachoroidea. Telachoroidea is a thin membrane, arachnoid-like membrane. This is a sandwich in between the tonsil as well as in fourth ventricle. And this is the telachoroidea is the arachnoid membrane, but below the telachoroidea there is a vascular layer of choroid plexus. So telachoroidea attached in the side of fourth ventricle by some white structure, and in the side of the roof it is also attached. So this knowing the anatomy and relation of telachoroidea is very important for entering or doing surgery in medulloblastoma. So knowing the choroid plexus of fourth ventricle. In fourth ventricle, the choroid plexus have two symmetrical halves, and it looks like a inverted L. The long arm of L is projected through the foramen of Lusca, and both transverse arm of inverted L is projected through foramen of mesentery. This is a suboccipital view of cerebellum and fourth ventricle. This type of view we can see during a normal person, especially in cadaver dissection. But when there is a tumor or any pathology or in this area, so this anatomy, this relation has changed. So a surgeon must know where is the location of tumor by seeing the radiology. A surgeon know the patient status clinically. A surgeon must assess or assume what are the changes he expect during surgery regarding normal anatomy. So he can approach nicely. So this is the expanded suboccipital view, but here the tonsil and biventral nodule is removed. So the telachoroidea is seen very nicely. There is a marking 3. 3, you see the telachoroidea. Telachoroidea is a thin, transparent layer. In front of telachoroidea, you see the granular choroid plexus, the long limb of L. Here is the long limb of L. So when we want to go through velar approach, that is the most better approach for reducing complication. We must know where is telachoroidea, how we enter through telachoroidea, what is the safest route for entry in the fourth ventricle. So this is the fourth ventricular floor anatomy. Details going through fourth ventricular floor anatomy is very tough within this time frame. We know most of the cranial nerve, lower cranial nerve, their nucleus is originated from fourth ventricle. If I grossly describe, there is a median sulcus which is divided fourth ventricular floor into symmetrical halves. This is a rhomboid shaped fossa. Just in the paramedian region, we get the motor nucleus, and in the lateral to motor nucleus, we will get the sensory nucleus. So the most prominent part, this 5, is the facial colliculus. We can divide the fourth ventricular floor into 3 parts. The middle part, there are some streak-like substance by which we can think it is a inverted triangle in the upper part behind the pons and midbrain, and it projected toward the aqueduct, opening of aqueduct. In the lower part, there is a V shape or triangular area, and this triangle is end in the obex. See, there is a marking 9, 10, 11. This is the most important area. This is the vagal triangle, hypoglossal triangle. This star mark triangle is the vagal triangle. For a life, vagal triangle is the most important. And because we know the vagus nerves control the cardiac function, respiratory function very nicely. So if there is any non-functional status in vagus nerve, vagal nucleus, so patient outcome will not good. So this is the details description of fourth ventricular anatomy. So another interesting thing, we always say fourth ventricle is a tent-like structure. Is it true? Fourth ventricle is a turnover tent. If we think it is a tent, so floor in the lower part, is it true? But in anatomical position, fourth ventricular floor is in the interior. So it is a turnover tent. But tenting anatomy is true when patient in prone position, that means in the surgical position. So fourth ventricular is a tent-like structure during surgery, but during anatomical position, this is a turnover tent. So when we enter in the fourth ventricle through this route, so what happens? We face a roof of interior roof of tent. So there are some hidden part in the apex of tent. We must keep in mind during surgery. This is the fourth ventricle important, very important picture. This picture is collected from Roton's book. Here, the tonsil and biventral lobe is removed. You see, there is a one mark for superior inferior Varnian vein. Every day, when we enter in the medulloblastoma, that means in the fourth ventricular tumor, we face this vein initially. So, if we sacrifice one branch, one tributaries of inferior Varnian vein, there is no problem at all. But please keep in mind, if we disturb both branches, so it may produce problem. So, if this bifurcation is too low, that there is a chance of rupture of vein during the surgical procedure, better to sacrifice one vein earlier. Otherwise, there is a chance of torn out of both veins. So, usually I saw most of the cases in pediatrics, this venous bifurcation is very low. So, we can sacrifice one tributaries. The second one is retrotonsillar vein. Usually we not face this retrotonsillar vein in our day-to-day surgery, but when the tumor is very big, it pushes the tonsil outside, so this vein may come in the surgical field. And another two things is superior cerebellar peduncle and vein of lateral recess in the fourth ventricle. This vein we faces frequently the small tributaries. The important thing, when we face or you face the vein of lateral recess in the fourth ventricle, don't proceed anteriorly, because in front of vein of lateral recess of fourth ventricle, that is the brainstem. So this is a good landmark also. Now comes to the famous so-called structure pica. We are always afraid about pica. We like pica. We want to see pica during surgery. Pica has 5 segments, but if for junior, for resident, my opinion, if you go through segment-wise, that is very clumsy. Rather, if you check all the courses, it is very easy. Pica originated from basilar artery or vertebral artery, whatever may be. There are 2 types of origin. And it goes and makes a hook round along the lateral part of the medulla oblongata, goes downward, makes a loop that is called caudal loop, goes straight upward and somewhat back, make another loop that is called cranial loop, goes most posteriorly and medially, makes another loop around the tonsil that is called pyramidal loop, below the pyramid, then it bifurcates to hemispheric branch, tonsillar branch in laterally and medially Varnian branch. This is easiest way to understand pica. If you want to understand a complex thing in a complex way, so it is very tough to memorize. But if you want to memorize a complex thing in a simple way, I think that is better. So there are 5 segments as per book. Inferior medullary segment. Here you see the long one, that is lateral medullary segment. The retrotonsillar segment, which we face during surgery frequently. That is the sixth marking, that is the supratonsillar segment that comes in the surgical field very frequently. Then the cortical segment, which we get in our surgery routinely. So this is a very interesting picture I collected from Sweet and Smidek. This segment, that is the 7 marking segment, that is posterior medullary segment of pica, we never see in a cadaver specimen very nicely like this one. What they do? They remove all the anterior structure, that means all the medulla oblongata. So they give a look from the fourth ventricular roof from anteriorly. That is a unique picture, I think. So here that is the superior cerebellar peduncle. The 2 is inferior middle cerebellar peduncle. 3 is the nodule. Nodule we face during surgery very frequently because tumor enter in the roof or apex of the tent. So this is the tent. This is the anterior roof of the tent. This is the posterior roof of the tent. So this is the tonsil, and this is another loop of pica, that is lateral medullary segment. So for resident, please check this picture from Sweet and Smidek book and try to understand this picture for getting more surgical understanding. This is the commonest picture we saw during our surgery. After just opening of dura, we see dura and arachnoid. We see this picture. So this is the terminal part of the pica branches. In the both sides, that is the tonsillar and hemispheric branch, and the in upper part, that is the Vermian branch. You can sacrifice the Vermian branch, but you can't sacrifice tonsillar branch very proximal, as because there are some small branch goes through tonsillar segment to brainstem. So this is a hidden cause of disaster during surgery. If we anyhow we burn pica proximal to this bifurcation. So this is another image of pica. So here is the foramen of Lusca. You see, this is the superior retrotonsillar vein of lateral recess of fourth ventricle. This is the Vermian branch of pica. So this branch goes to Vermis. So this picture we get after removal of tonsil and biventral nodule. So here the Vermian branch is nicely seen, and this branch goes to the hemisphere as well as tonsil. So what I say, if someone doing hemostasis pica here, that means in the proximal part of pica before the bifurcation, terminal bifurcation, so there is a chance of brainstem damage. So see in the right hand side where there is a marking 6, there are some small perforator originated from terminal pica, terminal but proximal pica, and it goes laterally and supply the brainstem. So be cautious about the pica. So evaluation of vascularity is an important factor before any surgery. How? We can evaluate vascularity by seeing the contrast. If some lesion uptake contrast very brightly, So we think this is a highly vascular lesion. But which vessel gives supply, which vessel not giving supply, that is important. So if we have facility, we can do, and if patient permit, we can do DSA before surgery. There are two benefits. One benefit, we can get good understanding of vascularity of lesion. Indeed, lesion is highly vascular, so we can embolize the lesion preoperatively. So less blood loss. You know, in pediatric, blood loss is an important factor for patient deterioration. So if possible, if patient permit, DSA is a good investigation before surgery. But another school of thought, in pediatric, DSA is not easy because you need general anesthesia for pediatric DSA. You need a small size of catheter for pediatric DSA. So there are two schools of thought. But here is some DSA of posterior circulation. Here you see there is a 9 marking, that is the supratonsillar segment of pica. In 11 marking, that is the posterior medullary segment of pica, goes from here. In 12 marking, that is the caudal loop of pica. In 13 marking, that is the lateral medullary segment. And in 14 marking, that is the anterior medullary segment, and red arrow indicate the origin of pica. So if you get the anatomy of pica and how much tumor blush is developed, tumor blush usually develop in meningioma, but any tumor, there may be some blush. So you can get a good understanding. So this is some other picture of pica. This is a very nice lateral view. Here you see the origin of pica in 5 marking, that is the caudal loop. In 4 marking, that is the posterior medullary segment. 3 marking, the hemispheric branch. In 2 marking, that is the Vermean branch. In 1 marking, that is the cranial loop. This picture I collected from Sweet and Smith's book. So this is a unique picture, I think. There are some more picture, anterior oblique view of pica and Townes view of pica. Now come to main surgery, hydrocephalus management. There is a lot of debate in every conference, in every center. There is a lot of debate regarding management of hydrocephalus in posterior to some aspiration. What we do? We do CSF diversion just after admission as early as possible, especially if there is a patient have headache, vomiting, or visual deterioration. We can do it available next operation day. Then tumor removal we can do around 2 weeks later. But what is the ideal situation? Ideal placement of a external ventricular drainage during surgery, or doing a so-called Frazier bar hole during surgery. If necessary, we can put a ventricular catheter through that bar hole. If there is a, we can drain the CSF as per necessary, and we can maintain height of external ventricular drainage. And after 3 days, we can check, that is called weaning program of external ventricular drainage after surgery. But what is the problem in our setup? We have no proper EVD weaning program. There is a lot of factor, but and if there is a need of emergency CSF diversion at the midnight, our patient will be at danger. So what we follow? We follow the traditional way. What neurosurgeon follow in last several couple of years or several decades. So doing CSF diversion as early as possible. Within 2 weeks, we can do the definitive surgery. But standard practice is EBD management, EBD weaning. So 40% of patients we can avoid permanent CSF diversion. So as because there is a lot of complication of permanent CSF diversion. So in case of 40% patient, around 40% patient, we can avoid that operation. Now cervical resection technique. During cervical resection, patient position is important. Dear resident, if you make a excellent patient position, you can pass as a neurosurgeon, you can do good surgery, I believe. But who are not able to do a excellent position, they will not get further. If we not unable to give your foot step in first stair, so how you give your foot step in second or third stair in your life? So please understand the patient position very nicely, meticulously, do it in your hand in operation theater. Don't rely on other person. If you do mistake, they are senior. We are always available in operation theater. Other senior also available. Take their help, but please do it in your hand and please study before every operation. Because there is a lot of good books of patient position in neurosurgery. There are so many positions we can advise for posterior fossa midline lesion. In pediatric, the prone position is the most common and most practicable position worldwide. Some position I can give some red mark. Dear resident, please check endotracheal tube during management of position. Please check BP monitor. Please check pulse oximeter. Please check ECG monitoring, micropore strapping of shoulder to gluteal region, gluteal support, cushioning below knee, cushioning below leg, cushioning in the para-external cushion. Please check catheter, IV line, and other armamentarium, monopolar diathermy connection, everything before dropping. Because if any monitoring or communication we lost during surgery, so there may be a disaster. So please check these and this thing. You may make a good checklist that what is the checklist for prone position. What is the checklist for terional position. So if you have a checklist and if you practice it for successive 10 cases, then the checklist go into your brain. You will not do any mistake in your life in the next time. So you can make a checklist. So sitting position, in some center, they practice sitting position. Sitting position is also good, but in pediatric, it is not widely practicable. And sitting position is good for short neck or where there is some neck pathology, because there is no need of extreme neck flexion. But Dr. Tarek discussed that what is the drawback, like air embolism, like cervical injury, like surgeon hand fatigue. That is the problem of sitting position. Now this is the opening. Dr. Tarek already mentioned that what is the extent of opening, how we open the ligamentum nuchae as well as fascia, how we doing a good craniotomy. What is our option, craniotomy or craniectomy? So Dr. Tarek already mentioned craniotomy is superior. Craniotomy we always want to practice, but sometimes if there is a brain swelling after operation, craniotomy don't give any extra space. So in that sense, craniectomy is good. But craniotomy give a normal anatomy. So normal anatomy has a lot of advantage. There is a less chance of adhesion, less CSF leakage, less postoperative pain also. So C1 laminectomy in some centers they do it routinely. I always prefer C1 laminectomy because there is a lot of advantage. There is a good microscope angulation. There is a good amount of CSF drainage through foramen of magnum, and there is a least amount of complication in C1 laminectomy. But in some cases where the tumor is very high up, you can avoid, but I always prefer C1 laminectomy. And in some centers, some surgeons, they're doing C1 laminectomy routinely. So dural opening. The most ideal and classical dural opening is Y-shape opening. But in low-lying small lesion, you can practice linear opening, but this is not practicable widely. Y-shape opening is standard and classical. So during dural opening, one thing is important in case of pediatric. In pediatric, there is a huge vascularity in the posterior fossa dura. Sometimes whole dura is converted to a venous lake. So there is troublesome bleeding during dural opening. What we can do, if we have a hemoclips, because if we burn posterior fossa dura, so dura will shrink. So during closure, you are in a trouble. So if we using a hemoclip or silver clip, that is not made by silver, but its name is silver clip now. And hemostasis is done nicely. So we can remove silver clip during closure, or some silver clip maybe stay there. It cannot produce massive artifact. So this is a small picture, but it can show that what is the normal anatomy and what is the pathological change in anatomy. So surgeon must understand what anatomical change during this patient surgery we expect, so surgeon can handle this patient in that way. So now we open the dura, open arachnoid, good amount of CSF sucked from foramen of magnum. We try to identify both pica, but it is not easy to identify both pica due to if this is a big low-lying tumor, or we can identify some cases. We try to remove the arachnoid band of pica and surrounding structure. So we can mobilize pica to few millimeters laterally. Then we can do lateral mobilization by pica. Some different people have different choice. This picture, they mobilize tonsil by sucker tube. Sometimes you can use a small spatula, but sucker tube should be guarded with cotton petting. So that is ideal. So there is a linear black marking I show here. That is the telomerular approach. And if we open the vermis from here, that is the transvernian approach. There is a lot of debate. In which case we can do this one. Telomerular approach is superior, no doubt. But for a big lesion, that is very tough to go through the telomerular approach. For a very high up lesion, it is tough to go there through telomerular approach. So things should be customized for each patient. We cannot hard and fast do telomerular. In every case, I can do transvernian. That is not the rule. You can choose your approach according to location and lateral expansion of tumor. The tumor vascularity is the important factor also. If there is a highly vascular tumor, better to go through transvernian. So there are 4 important landmarks: 2 pica, ventricular floor, and aqueduct. At the beginning, we want to see 2 pica. Just after some tumor removal, we want to see ventricular floor. We must give cotton patty in the ventricular floor to protect it. And After removal of the most of the tumor, that means 80%, 90%, we try to want to see the cerebral aqueduct. Sometimes there are some tumor pushes or suck within the aqueduct. We must remove it under the microscope. So that is the 4 important landmark. That is the cerebral aqueduct, 2 pica, and 4th ventricular floor. So now I want to show you 2 small video. This is the dural closure. There is a lot of debate that what is the ideal rule of dural closure. I saw some surgeons, even in overseas country, they are doing duroplasty routinely. They have 2 points that duroplasty give you some lax situation, so brain can expand. Duroplasty can reduce the CSF leakage. But if you have good dural substitute, which is absorbable, so you can do it routinely. But if you have no absorbable dural substitute, you can use cervical fascia. That is an excellent alternative of duroplasty by artificial dura. But in pediatrics, sometimes cervical fascia is not well developed. In that case, we can do duroplasty if necessary. So meticulous closure of subcutaneous tissue and skin is important. Postoperative complication. There is a lot of postoperative complication like other neurosurgery, but 3 complications is important. One is pseudomeningocele or CSF leakage. If we close the dura, use the craniotomy very nicely, so there is a least chance of pseudomeningocele, and if there is a CSF diversion, there is less chance. Cerebellar mutism usually occurs after transvernian approach. If we go above the level of fastigium, because dentate nucleus is there. Dentate nucleus has some crossing at the level of fastigium. So if we disrupt the crossing, so there is a chance of cerebellar mutism. There is another important group of complications that can hamper patient life. One, post-op long respiratory depression, post-operative prolonged unconsciousness, and post-operative cardiorespiratory instability. These 3 usually not happen in every case. If there is huge amount of tumor adherent with floor of the 4th ventricle, so there is a chance of post-operative complication like this. In that case, we can keep some amount tumor, a thin layer of tumor within floor of the 4th ventricle. So keeping a thin layer with the floor of the 4th ventricle, if it is adherent or infiltrated, is not a problem at all. Oncologists regard it as a gross total removal. So I can go to the video. Before going to video, I asked Dr. Nafaur Rahman. Nafaur Rahman, are you in online? Nafaur?
Are you there, Nicole?
Nafaur, are you in online? Oh, Nafaur is not yet, so I can continue. So I can share another one video. So the first video.
If you want the 4 coming in,
Yeah, the 4th speaker is Dr. Nafaur Rahman.
yeah, he's here, he's coming in, the fall Raman.
He is coming.
Yes.
Dr. Nafaur,
The 4, are you there? Dr. Raman?
Dr. Nafaur, if you are available, so I will not show the video. Oh, Nafaur is available. Nafaur, please.
He's in there. But he's not speaking. Can you hear us, Dr. Ramos?
Dr. Maidullah Tariq, give a phone call to Nafaud.
He's there.
He's on mute.
Yeah. Unfortunately, I can't unmute him. Nafar, you have to unmute yourself. I can ask you to unmute.
If Nafaud not available, so I will show one small video.
Okay.
So this is we have several video of medulloblastoma surgery. So this is surgical video where we show that how tumor is separated from surrounding parenchyma. Here we
Excuse me, so if it's not playing, the video is not playing.
oh, video not playing.
Yeah, could you try it again, please? Click it again.
Here there is some problem regarding video in my computer.
Try it again. It might work. Let's try it again. Or you can leave the screen and come back. Yeah,
Okay, I can start another. Is it visible?
okay, let's see if it opens.
It's
You know-
loading.
It's open.
Yeah.
Oh, okay.
Just wait. We'll wait. Just wait a second. It might open up, hopefully.
So this one is running now.
Apparently it's not. Yeah, I think, yeah, it's a computer. Okay, so I think we have to move on.
It's moving.
Yeah.
John,
but,
you see the video?
yeah, I see it, but it's not even loading now. You try it again. You want to reboot? You want to leave and come back? Or go off the screen and come back? Go off the screen and come back. Try that. Look, in other words, take it off the screen and then, okay, now try it again. Come back.
Nafaur, are you available?
Nothing's working today.
Okay,
Okay, it's on. There you go.
It's working.
Yes.
working.
Yes.
Okay, so I can show this is a small video. This I record during a surgery just last month. Here for resident I show that this is the tumor. This tumor comes out through the foramen of Lusca and it pushes the tonsil upward and laterally. So how much anatomy is distorted? For this case, if I want to see the pica in earlier stage, it is impossible or there is a chance of injury in the brain stem. So what I can do for this case, I can remove the arachnoid, opening foramen magnum, and after opening foramen of magnum, suck out a considerable amount of CSF, then try to differentiate the cleavage between tumor and normal brain, that means tonsil and biventral lobe. After then, when I do some decompression, here I am doing the separation of tumor and cerebellar parenchyma. After some decompression, then I try to get anatomical landmark. So it is not always the anatomical landmark we get just after entry. Here we try to remove the tumor from the lateral part. This is the pseudo cleavage in between tumor and parenchyma. Due to compression of tumor, the white matter form a pseudo cleavage or pseudo line. That is a whitish line where dotted blood we found. There is look, there is a whitish area where the dotted blood is found, there is not, and getting that type of area give a good perception to surgeon's mind. Yes, I am in the end point of that side. So after removal of some tumor, we push a sizable cotton patty in between tumor and that parenchyma and remove more and more tumor, debulking done. After good amount of debulking, we will get, this is a unedited video, so in all place there is not under good focus. So after getting the, see there is the cleavage, excellent cleavage, but that is, keep in mind, this is a pseudo cleavage. This is not a true cleavage. So after removal, a significant amount of tumor, then we can try to find out the pica. What is my perception in medulloblastoma surgery when I loses the path? That means when I lost the navigation in my brain, so I can go further down. I remove all the cotton patty, go to the CB junction, try to check fourth tonsil, try to check foramen of Lusca, then I go to the cervical field again. That is the way I can try to find out myself, where am I? Because sometime during surgery, I think most experienced surgeon even, they can lose their field. They can lose their exact position. So for posterior fossa midline tumor, when I lost my position, that means I am in confusion that where I am. So I can go down, remove all the cotton patty and check the anatomical structure. Then I can proceed further. That is my perception. So everybody when doing a significant amount of surgery, so they develop their own perception that how can he proceed. This is the side of another pseudocleavage. So as because this is the unedited video, in every part there is not same picture. So I think we are at the end point after the hemostasis. This is the picture. So our joint director sir is with us. So we are so fortunate, and I tell my gratitude to our joint director sir. During couple of weeks back, we had an international conference in Intercontinental Hotel, where I show a video of our new flexible chip-on-tip endoscope to in front of international community. Someone you may know the name of Professor Frederick Books. He is the chairman of neurosurgery of University of Texas. He just accomplished that video from the dais. He said a word only, that I feel jealous to see your video, and I have not this endoscope in our center, and how you manage this endoscope. I tell, believe me, I give him an answer that our JD sir know how this instrument is managed. He asked me after the conference that who will know this, how he manage it. I tell him that JD sir means joint director sir. We tell him that we need this instrument, how he manage, from where he purchased it, he knows. That we are fortunate that we have very good quality microscopes, almost all type of endoscope, and navigation, intraoperative monitoring system, and we have almost all available facility. What we know, maybe beyond our knowledge, there is a lot of instrument, but sir is the main person who can manage, and if some neurosurgeon from our side go to him and they tell that, sir, we need some tiger meal for our good operation. He just want to assess it, is it really necessary or not, and he can manage it. So I think we are fortunate enough in our institution. Sir, please, then panelist Jahid sir will say something.
Thank you. Thank you, Dr. Sudipto. Actually, this is your effort, not my alone. But I'm surprised to hear all the members of our pediatric neurosurgical team, particularly the residents, and also Dr. Arman and you also have given a good lecture. And that is very much important for us, as because what the neurosurgeon, particularly the pediatric neurosurgeon, is going to do in our institute, it is our remembering focus that everybody is knowing our work that you are doing every day. Particularly the resident who have described their different approach for a neurosurgical operation. That is very important for the students, particularly the residents of all over the world, to know what approach we should do, what is the advantage, what is the disadvantage of the different approach. And actually, I am not a neurosurgeon, I am a neurologist, but a few moments that I have achieved the neuroanatomy. Actually, my mentor, Professor Dean, always says one word: neurosurgery and neurology is the neuroanatomy. So the 1.5 hour lecture from you, particularly the residents, they have pictorial presentation regarding the neuroanatomy of the different perspective of the operation. That is very tremendous, very good, and that is very appreciating for a resident. For Arman, I think he has described the craniopharyngioma, different types of craniopharyngioma, particularly the operation and the operative complications of the craniopharyngioma. For a neurosurgeon, from the neurosurgeon, I am expecting or minimizing the complications and the postoperative complications of the craniopharyngioma. John can describe, and Professor Jahid can give us some idea how we will minimize the postoperative complications of the craniopharyngioma, particularly diabetes insipidus, obesity, and the long-standing steroid effect. And Professor Dr. Sudipto, you are the head of the department now, and you are running the department, and all the things you are doing. Actually, we are giving some facilities or procuring some instrument for you, but you are the person. You developed your team. And I am saying that for your capacity, your charisma, you have developed a new pediatric neurosurgical team in Bangladesh. So believe me or not, we are only helping you to complete important instruments that are equally procurable in all parts of the world. So your effort, your charisma, your activities, and your team enforcement give us some idea to procure some of the instrument. And you have given some idea regarding the medulloblastoma. Yes, this is very important, particularly those people who comes with medulloblastoma. That is very important task for operation and survivability. And you have seen that before doing the elective surgery, you do some hydrocephalus before doing surgery. But I think the days are coming when both the surgeries are doing in a single sitting. And I'm eager to know from John that what is your approach regarding the medulloblastoma, that before doing the elective surgery, do you do the hydrocephalus surgery first, or it is almost the same table? And I'm also expecting Professor Jahid also tell us something regarding the medulloblastoma in adult and pediatric. Is there any effect? So from a brief view, I am very much enlightened, and I think that replenish my that is the neuroanatomy, and I thanks all the presenter, all the participants, that we have achieved a lot from the neurosurgical, pediatric neurosurgical team from Neuroscience of Bangladesh. Thank you again.
Right, sir, please.
Professor Jahid.
Can you hear me?
Yes,
Yes.
yes.
Can you hear me?
Yes, yes.
Yes,
Dr. Sudipta?
yes, sir. We can hear you and see you.
Okay, thank you very much. I was hearing almost all the lectures with some interruption. Probably it was due to my handset. In between, I could not follow all the things. But the thing is, most important thing is today you have discussed two most important approaches to the brain. This is supratentorial for supratentorial, the pterional approach. It is the most versatile approach to the supratentorial compartment of the brain, and no other approach for supratentorial one is like this. This is the only approach which can deal almost 70% of the brain pathology through this only pterional approach. This is a very versatile approach, and it can approach from frontal to occipital. From frontal to occipital, it can and cover all these things from anterior circulation to posterior circulation, basilar tip. All these things can cover through this pterional approach. So it is very important. And you, this is Mr. Dr. Shoikat. Dr. Shoikat is very nicely, and we have seen many things through this lecture. One thing I can tell, one picture Dr. Shoikat was telling, a para-operative picture of thing, but that was the book picture. So Shoikat, be careful of these things always. Para-operative picture and book picture is not the same thing. You can tell it the para-operative book picture. It was you have taken it from book, and so always be careful about the references because
Okay, just wait a minute. He'll come back. Just temporary. Well, it's a little longer than usual. Okay, so Depp, I think we need to continue.
Possibly his net disconnected.
Yeah. I think, can we move on, Sadepka?
We can wait for a couple of seconds.
Okay,
Possibly
Okay.
he will come back.
okay.
Hi, Kong, can you say something?
yes, Dr. Sudipta, can I
Yes, sir.
continue?
Yes, sir.
Okay, all right.
Yes, can I
Yeah.
continue?
Yeah,
Sure.
Okay, then I was telling about the Dr. Tariq. He was very nicely described the posterior fossa craniectomy or craniotomy, and you have described the posterior fossa surgery. Our joint director sir was telling asking two questions. One is while you are doing operations for medulloblastoma, whether it can be managed in one sitting. I can tell the sir for the lady sir during we can do one brazier barrel and place a tube in the posterior horn of the lateral ventricle and keeping it closed. And during surgery, after medulloblastoma surgery, if we see the CSF flow from the third ventricle to the fourth ventricle is all right, and when we look through the aqueduct of Sylvius, free flow of CSF through the aqueduct into the posterior fossa, that is fourth ventricle. In that case, the BV shunt is not needed. If CSF flow is not adequate, there is no free. In that case, you can this external shunt in one sitting. This is the way of doing both the things in one sitting, both BV shunt and tumor surgery. Otherwise, but some cases the second sitting is needed, but we can do it in same sitting even. And another one thing was sir was telling the postoperative diabetes insipidus in craniopharyngioma surgery. It is very difficult because craniopharyngioma tumor is very firmly adherent with the structure surrounding the jaw. If pituitary damaged or injury, but all the DI are not permanent. The DI mentioned permanent to prevent these craniopharyngioma during, in that case, craniopharyngioma recurrence is in, but in most of the cases, craniopharyngioma is usually recurrence is there, but if we deliberately keep some tumor tissue along with the stop, in that case it will recur. For Dr. Arman, you are telling about the pituitary surgery, craniopharyngioma surgery, so nasally, that is endoscopic, endonasal, and transcranial. I can tell only sellar craniopharyngioma should be operated endoscopically. Otherwise, if it is sellar extension or suprasellar lesions, if you do it endonasally, there will almost many cases recur. So in that case, recurrent approaches to endonasally will lead to CSF leakage. So for this purpose, the suprasellar lesions especially for craniopharyngioma should be through a transcranial approach. It will be better for minimizing the complications of CSF leakage for craniopharyngioma. And other things, I think many very nicely you have described. Oh, thank you very much, Dr. Sudipta, for inviting me as a panelist for your session. But I appreciate you to arrange this sort of webinar, and it is very important and very useful for our residents to practice and to deliver them in like this webinar. Thank you very much, and thanks to Joint Director Sir for his with this session. Thank you again, sir.
Thank you, Professor Jahid Hossain sir, for inspiring our team pediatric neurosurgery. Dr. Nafaur Rahman is online, possibly some technical problem. I think in the next session, in the last session of this series, he will present his ependymoma nicely. So today we deserve some closing speech from sir, and please John will close the session.
Well, I'd like to thank everybody for participating, and thank you, Sadeka, for putting this together. It's not easy, I know, and I really appreciate you making all the efforts and getting it together. And to all the people that presented, thank you very much. You're winning this. You're making it very valuable for a neurosurgeon in Bangladesh to have access to knowledge like pediatric neurosurgery, which they wouldn't be able to do. They have it accessible from a computer. I think it possibly can benefit a lot of residents in Bangladesh in neurosurgery as well as across the world. So we look forward to seeing the next part in 2 weeks. Sadevka.
Okay, thank you very much.
Thank you very much.
Thank you, sir. Thank you, John. Thank you, Jahid, sir. See you.
And thank you, Mila.
Thank you, Mika.
Yeah, thank you all. Okay.
Okay, very
Thank
good.
you. Okay, thanks.
Okay, we're off the air. Off the air. Thanks everyone for participating. Yeah, we had a little discussion there at the end. That's good. That's good, Bedrul. Are you from Dhaka, Bedrul?
Yeah,
Yes,
thank you, sir. Thank you. I am
he
from
is our
Dhaka.
teacher, and
Okay.
we are working in his institute.
Oh, okay.
Dr. Sudipto is a very good organizer, good leadership quality, and he developed a team in our institute that we are running ahead. And please help us for the training and also the just like this type of webinar that give us some idea regarding the latest update of the neurosurgery in pediatrics.
So you're at the same hospital
Yeah.
as Sadipka?
Yeah.
Yes,
Yeah,
yes, sir.
Oh, great. Are you there, Mila?
Yes, I'm so sorry.
Because this is
My Wi-Fi was cutting. Now it's
this is
working.
Mila. She's not a medical student. I call her a medical student. Yes, she's the neurosurgeon from Turkey, now in Russia.
Yes, from Saudi.
And she's starting to do some announcing.
Thank you so much, professors, for this amazing opportunity. I learned a lot today, and I hope we can have more like residents, especially like me, who can like present topics, and it would be really an amazing opportunity. Thank you, everyone.
Yeah, in 2 weeks, there's another webcast on pediatric tumors. So
Okay.
Yes.
we look forward to seeing that. Okay, Mila, hang around. We'll chat a little bit.
All right.
Yeah, I'm just gonna speak, well, like, there's no rules. You've done presenting all your career. So, this is nothing strange to any medical person. And once you start doing it, just like riding a bike, you just jump on the bike and you ride, and you don't really intentionally ride it, but you just ride it. And you did a good job. And, I was going to say to you, really what we need you for is to introduce the people
Yes.
at the beginning. And then really, because I know like there's a lot of webcast, like today there was like 5 presentations. And I know you're a busy person. I called you at the last minute. You're certainly welcome to stay for 1 or 2 and just do your work and possibly come back. But really, at the beginning is the only time but you're welcome to stay. But if you're really busy, you could say to me, Dr. Bennett, I'm busy, but I'll be glad to introduce somebody. And
All right.
that would be fine. That would be fine. So,
All
okay, then we'll see everybody.
Thank you, everyone. Have a nice day.
Yeah, you guys are gonna come, I hope, to tomorrow's webcast. Let me show you. I know Milo's dying to see this. She's probably
Yes.
heard too much of it in the last couple of days. And that's all I've been talking about. Yeah, let me get the let me screen share. It's the biggest webcast of the year, and I think it's one of the best. Of course, I'm kind of biased a little bit, but I didn't put this conference together. Sam did, Sam El Morsi, and I'm going to show you the people that are involved is where and can't get it here. I'm sorry, folks. I'm not getting the screen. Oh, okay. Here we go. Okay, it's a third world skull-based Congress. And a lot of top names are here. You recognize probably Sufinov, Campero, Herrera, Goel. I'm sure everyone recognizes him. Diu Pujari from India, Kanan from Saudi, Sabea from Palestine, Sorelli from Italy, Marcos from Miami, Cherian from India. As you can see, we have a lot of good people that are going to be there tomorrow. It's going to be all weekend, Saturday and Sunday. So please stop by. Okay, then we're going to get ready to promote that baby.